atrial fibrillation is frequently associated with pathological atrial myocardial dysfunction and remodeling. This triad has been called atrial myopathy. Atrial fibrillation can be the cause of consequence of clinical heart failure, and the directionally varieties between individual patients and across the spectrum of heart failure. Although initial trials suggested no advantage for a systematic rhythm control strategy in heart failure with reduced ejection fraction, recent data suggest that select patients may benefit from attempts to maintain sinus rhythm with catheter ablation. The modern management of atrial fibrillation in heart failure also requires consideration of the degree of atrial myopathy and chronicity of atrial fibrillation, in addition to the pathogenesis and phenotype of the underlying left ventricular heart failure. Our next speaker will brief us on the personalized approach to atrial fibrillation patients with heart failure across the spectrum of ejection fraction. Dear Michael Deshko, you are welcome.
Good morning, dear colleagues. The topic of my today's talk is personalized approach to atrial fibrillation in patients with heart failure across the spectrum of ejection fraction. Incidence and prevalence of both atrial fibrillation and heart failure are increasing in contemporary populations, and they often coexist. In the European Society of Cardiology Heart Failure Long-Term Registry, approximately 1/3 of all patients with heart failure had also atrial fibrillation, irrespectively of ejection fraction category and patient gender. However, atrial fibrillation was particularly common among those with heart failure with a preserved ejection fraction. If to look into heart failure prevalence among patients with atrial fibrillation, it ranges 30 to 60%, as appears from the cohorts or the phase 3 trials in which safety and efficacy of direct oral anticoagulants versus warfarin were compared. Furthermore, it's clear that the risks of cardiovascular events and also stroke and systemic embolism are dynamic and are increasing over time in patients with atrial fibrillation because of aging and development of other diseases. For example, while patients may not suffer from heart failure at onset of arrhythmia, estimated annual risk of heart failure development is up to 3%. Apparently, co-presentation of atrial fibrillation and heart failure worsens prognosis of each other. For instance, while prognosis of patients with a HFpEF appears to be better than that in patients with a HFrEF on sinus rhythm, mortality and hospitalization rate increased dramatically among heart failure with a preserved ejection fraction patients with atrial fibrillation towards that observed in HFrEF and sinus rhythm. And vice versa, while stroke prevention is among top priorities in atrial fibrillation management, in well anticoagulated patients, cardiovascular causes, including heart failure, appear to be a major contributor to mortality of patients with arrhythmia. Classification of heart failure into 3 ejection fraction categories has been introduced since 2016 European Society of Cardiology Heart Failure Guidelines and has undergone several updates in 2021, as highlighted on the slide, with respect to ejection fraction cutoffs, criteria of diastolic dysfunction, and separate criteria for atrial fibrillation patients. These updates are particularly worthy for appropriate diagnosis of HFpEF in combination with atrial fibrillation that probably represents distinct phenotypic pattern of HFpEF. Nonetheless, above-mentioned classifications has limitations regarding, first of all, HFpEF and HFmrEF, heart failure with a mildly reduced ejection fraction. What are they? Variability of terms and definitions, including those for preserved ejection fraction, with the cutoffs of 40%, 45%, 50%, etc. Classification criteria available so far as European Society of Cardiology HFA PEF algorithm, H2 FPEF algorithm, aid making diagnosis, but may suffer from variability of sensitivity and specificity in various cohorts of patients. Risk of adverse events in HFpEF and HFmrEF is lower than in heart failure with a reduced ejection fraction, though higher than in general population. And atrial fibrillation worsens outcomes in all categories of ejection fraction. Limited evidence for medical therapy is available so far. Efficacy for surrogate or soft endpoints largely is demonstrated, while no medications are available to reduce mortality, as available for heart failure patients with a reduced ejection fraction. The task force that worked on 2023 focused update of the 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure discussed changing in the description of heart failure with a preserved ejection fraction to heart failure with normal ejection fraction, and the left ventricular ejection fraction thresholds for heart failure with normal ejection fraction. So far, they decided to keep the term heart failure with a preserved ejection fraction and left any further changes in terminology to be considered in the next ESC heart failure guidelines. Within the Europe and many other countries in the world, the atrial fibrillation better care, so-called ABC pathway, is the gold standard of integrated holistic care strategy for atrial fibrillation management. Atrial fibrillation diagnosis should be confirmed and characterized prior to implementation of ABC pathway components, including A for avoiding stroke and anticoagulation, B for beatless symptom control with rate or rate control or rhythm control strategies, and C for cardiovascular risk factors and concomitant diseases management. Let's discuss briefly utilization of each of these aspects in heart failure depending on ejection fraction category. As mentioned above, stroke and systemic embolism prevention remain among top priorities in the management of atrial fibrillation. If to refer to classical definition of C as heart failure component and stroke risk in the CHA2DS2-VASc score is defined as moderate to severe systolic dysfunction or recent heart failure-related hospitalization, irrespectively of ejection fraction, and also hypertrophic cardiomyopathy is included. However, if patient has normal or preserved ejection fraction and no recent hospitalization due to heart failure exacerbation, it's still very likely that oral anticoagulation will be recommended and beneficial to such a patient because heart failure patient with a preserved ejection fraction and HFpEF itself tightly correlates with other stroke risk factors as arterial hypertension, aging, diabetes mellitus, vascular disease, etc. So patient most likely will have even more than one additional stroke risk factor that necessitates oral anticoagulation. In terms of rhythm control strategy in the management of patients with atrial fibrillation, current guidelines on atrial fibrillation advocate rhythm control strategy for reduction of atrial fibrillation-related symptoms and improvement of quality of life as the primary indication. However, rhythm control seems to provide benefits beyond symptomatic improvement. As atrial fibrillation begets atrial fibrillation, sinus rhythm begets sinus rhythm. Following no difference in survival observed in historical affirm study that compared rhythm and rate control strategy during 5 years of follow-up, retrospective analysis of more recent cohorts consistently showed risk reduction of thromboembolic events and mortality with lower burden of atrial fibrillation. That is, in paroxysmal atrial fibrillation compared to non-paroxysmal types of arrhythmia. Important evidence regarding the effect of early rhythm control therapy on clinical outcomes has been provided by the EAST trial, where prospectively recruited patients with atrial fibrillation diagnosis within 1 year underwent rhythm control either with antiarrhythmia agents, cardioversion, or ablation compared to rate control. Utilization of rhythm control strategy led to significant 21% reduction of combined endpoint of cardiovascular mortality, stroke, heart failure-related hospitalizations, and acute coronary syndrome. With respect to catheter ablation as an option for rhythm control in atrial fibrillation, the highest 1A class of recommendation was assigned to catheter ablation as initial mean of rhythm control in atrial fibrillation following CASTLE-IF trial in patients with a reduced ejection fraction. The trial included patients with paroxysmal and persistent AF and HFrEF referred to ablation in comparison to medical therapy. Catheter ablation was associated with a 38% reduction of risk of primary endpoint of all-cause mortality and heart failure-related hospitalization, significant improvement of ejection fraction, distance passed during 6-minute walking test, and decrease in atrial fibrillation burden. Benefits of atrial fibrillation ablation in heart failure with a reduced ejection fraction in CASTLE-IF trial, at least in part translated to those in patients with a HFpEF. You can see such of these studies on slides where ablation comparison to medical therapy decreased progression of paroxysmal atrial fibrillation to persistent atrial fibrillation. Also, catheter ablation led to significant reduction of NT-proBNP level and improvement of New York Heart Association functional class of heart failure, while increasing NT-proBNP and worsening of heart failure symptoms were observed in medical therapy group. The risk of hospitalizations was significantly reduced following atrial fibrillation as well in this study. However, the limitations of this study as a single-center case-control study have to be acknowledged. Results cannot necessarily be generalized, and other studies in the topic in patients with a HFpEF and atrial fibrillation showed less positive conflicting results. Therefore, randomized controlled trials are warranted. Rate control therapy could serve as a baseline strategy for all patients with atrial fibrillation in order to reduce symptoms and prevent progression of atrial fibrillation. It's also the last choice when patient failed to stay on sinus rhythm after attempts of cardioversion, either pharmacological or electrical. Rate control can be achieved with beta blockers, digoxin, diltiazem, or verapamil, or combination therapy depending on ejection fraction, comorbidities, and presence of pre-excitation. Beta blockers are often first-line rate controlling agents, largely based on better acute rate control. However, non-dihydropyridine calcium channel blockers provide reasonable rate control too. Amiodarone can be useful as well in combination with beta blockers, particularly in patients with a heart failure with a reduced ejection fraction, and when monotherapy did not allow to keep and reach control of heart rate in patients with a atrial fibrillation. And also appropriate when patient is not suitable for the ablate and pace strategy, that is the last resort to reach control of heart rate. Interestingly, the prognostic benefit of beta blockers seen in heart failure with a reduced ejection fraction in patients with sinus rhythm has been questioned in patients with atrial fibrillation. This was demonstrated in individual patient data meta-analysis, where there was no difference in survival in patients with atrial fibrillation, irrespectively whether they received beta blockers or not. So authors conclude that no preference should be given to beta blockers for rate control in atrial fibrillation compared to other rate lowering agents. However, there are studies which confirm survival improvement with beta blockers use in heart failure and atrial fibrillation, as it was observed, for example, in large nationwide cohort study from Denmark. Observational studies have associated digoxin use with excess mortality in atrial fibrillation patients. However, this finding was likely due to selection and prescription biases rather than harm caused by digoxin directly, particularly as digoxin is commonly prescribed to sicker patients. Lower doses of digoxin may be associated with better prognosis, and in specialized centers, measurement of digoxin concentration may aid and improve safety of patient treatment with digoxin. Interestingly, the only one face-to-face comparison of rate-lowering agents, that is RATE-AF study, showed better improvement of atrial fibrillation symptoms as defined by ERA class improvement with digoxin compared to bisoprolol. In terms of C component in ABC approach to patient management, active and perhaps proactive risk factor management of cardiovascular risk factors and extracardiac conditions, including blood pressure control, diabetes mellitus management, lipid-lowering therapy, weight reduction, screening for obstructive sleep apnea and CPAP therapy where appropriate, smoking and alcohol cessation, and other risk factor management is essential for improved outcomes across all aspects of atrial fibrillation management, for safety and efficacy of oral anticoagulation, for rhythm control, prevention of heart failure development and worsening, and so on. What do guidelines say in terms of heart failure therapies in the population of atrial fibrillation patients? Well, recommendations are clearly consistent within atrial fibrillation and heart failure guidelines. Heart failure therapies to improve survival and reduce hospitalizations and symptoms have to be administered irrespectively of rhythm status. Noteworthy in atrial fibrillation patients, pharmacological treatment of heart failure is also essential part of so-called upstream therapy directed towards prevention and of progression of structural remodeling and structural substrate of arrhythmia. In heart failure with a reduced ejection fraction, pharmacotherapy is well established, and now it looks as quadritherapy for components therapy and includes AC inhibitor, beta blocker, mineralocorticoid receptor antagonist, and one of SGLT2 inhibitors, either dapagliflozin or empagliflozin, which have to be prescribed together simultaneously unless there are contraindications or patient cannot tolerate one of them. AC inhibitors can be replaced with angiotensin receptor blockers in case of side effects or intolerance to AC inhibitors as dry cough, or to angiotensin receptor neprilysin inhibitor as sacubitril valsartan. Very important note is, while you improve ejection fraction in a patient with a heart failure with a reduced ejection fraction over 40%, that means that a patient moves to the category of mildly reduced ejection fraction, or sometimes defined as heart failure with improved ejection fraction. The therapy has to be continued. In terms of management of heart failure with a preserved ejection fraction, until recently, no treatment has been shown to convincingly reduce mortality and morbidity in such patients. None of the large randomized controlled trials conducted in HFpEF have achieved their primary endpoints, where the improvement were observed. Positive results were observed for surrogate endpoints as NT-proBNP reduction, peak oxygen consumption, diastolic function parameters as E to E prime ratio. Furthermore, definitions of ejection fraction overlapped in these trials with each other, and heart failure with a preserved ejection fraction cohorts included partially those with a heart failure with mildly reduced ejection fraction. Following failure to achieve their primary endpoints in randomized controlled trials, attempts to find specific phenotypes in which studied treatment could be effective have been made. Indeed, patients with a heart failure with a preserved ejection fraction represent heterogeneous population. Interestingly, atrial fibrillation is tightly linked to heart failure with a preserved ejection fraction, and it was present in every patient group or cluster in one of such studies, representing 31 to 83% of cases. TOPCAT trial, in which spironolactone was studied for HFpEF management, is one of examples of drug efficacy in selected phenotype despite neutral results in the whole cohort with respect to primary endpoint of CV mortality, heart failure-related hospitalization, and aborted cardiac arrests. Specifically, spironolactone reduced the risk of primary endpoint by 25% in those patients who were obese or had diabetes, who had higher degree of inflammatory markers as TNF-alpha, characterized with abnormal metabolism, liver and renal injury or dysfunction, had higher renin level. These findings are interesting, but may be used as hypothesis generating findings only, because it's hard to apply them to real-world practice. There have been certain expectations from sacubitril valsartan therapy, given that phase 2 study Paramount that showed the level of NT-proBNP in patients with a HFpEF to be reduced significantly in the treatment group than in the valsartan group after 12 weeks. Also, after 36 weeks of treatment, the left atrial volume in the treatment group was significantly lower than that in the control group, and the cardiac function in the treatment group was significantly better than that in the control group. Please pay attention that in phase 3 PARAGON-HF trial, 45% as diagnostic cutoff for preserved ejection fraction was used in line with the NT-proBNP level as compulsory inclusion criteria. Also, CV mortality and heart failure related hospitalization combined endpoint was used as primary endpoint. Results of the PARAGON-HF trial have been extensively discussed. The study did not achieve its primary endpoint, and sacubitril valsartan was better than valsartan only in females and lower range of ejection fraction, specifically below 57%. Empagliflozin was claimed as the first effective treatment for patients with HFpEF following the results of EMPEROR Preserved trial. Indeed, 10 milligrams of empagliflozin once daily resulted in 21% risk reduction of combined endpoint of CV mortality and heart failure hospitalizations. However, the effect was mainly driven by reduction of heart failure hospitalization with empagliflozin, and there was no reduction in cardiovascular death. Cutoff of 40% was selected, referring to CHAM program with candesartan, where the term preserved ejection fraction was used for the first time, and NT-proBNP levels greater than 300 picograms per milliliter in sinus rhythm and greater than 900 picograms per milliliter for atrial fibrillation patients were used as mandatory inclusion criteria. In some group analysis, empagliflozin was effective independently on diabetes and rhythm status, both in males and females, on the contrary to sacubitril valsartan PARAGON-HF trial, and in ejection fraction range up to 60%. Later on, the DELIVER trial with the dapagliflozin reported consistent with the empagliflozin results. Again, patients had to have a left ventricular ejection fraction greater than 40% as a criterion for preserved ejection fraction. And at the time of the recruitment, elevated concentrations of natriuretic peptides should be observed. Importantly, even those patients who had reduced ejection fraction initially less than 40% and then improved to greater than 40% were also eligible for the study. Dapagliflozin reduced the primary endpoint of severe death or worsening heart failure. However, even in subsequent aggregate data meta-analysis of the two trials, SGLT2 inhibitors did not reach the level of significance for cardiovascular death reduction. Last recommendation for heart failure with a preserved ejection fraction appears in guidelines as an SGLT2 inhibitor, dapagliflozin or empagliflozin, is recommended in patients with a heart failure with a preserved ejection fraction to reduce the risk of heart failure hospitalizations or cardiovascular death. Similarly, given that EMPEROR Preserved and DELIVER trials included patients with ejection fraction greater than 40%, that currently refers to mildly reduced ejection fraction, recommendations sound for patients with heart failure with mildly reduced ejection fraction. Returning back to the history of management of HFpEF with candesartan in CHAMP program, CHAMP resolve study specifically, that showed borderline significance for cardiovascular death and heart failure-related hospitalization reduction. The question then arises as to what if add NT-proBNP level to inclusion criteria in CHAMP resolved patients. In summary, the treatment of atrial fibrillation and heart failure should include long-term, lifelong oral anticoagulation in atrial fibrillation and heart failure with a preserved ejection fraction and other ejection fraction categories. Proactive control of cardiac and extracardiac risk factors for effective and safer oral anticoagulation, better rhythm control, and prevention of heart failure progression. Rate control as baseline strategy, but also consider early rhythm control, including catheter ablation, taken into account atrial fibrillation history, comorbidities, symptoms, patients' values and preferences. Phenotyping of patients with heart failure is increasingly utilized where atrial fibrillation is likely to be independent phenotypic pattern of heart failure, particularly in heart failure with a preserved ejection fraction. However, at the moment, it's hard to utilize this approach in routine practice. SGLT2 inhibitors for the whole spectrum of ejection fraction in heart failure are now recommended. However, positive results in trials were determined largely by heart failure-related hospitalization and not separately by cardiovascular mortality. Application of criteria and results of trial with ARNI and SGLT2 inhibitors like lower range of ejection fraction, increased baseline level of natriuretic peptides, make all the treatment options like AC inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists potentially effective in patients with a heart failure with a preserved ejection fraction and heart failure with a mildly reduced ejection fraction too. Thank you for attention and have a nice day.